Hi, my name is Brett Parker, and I'm a minimally invasive surgeon at Johns Hopkins University. I'm an assistant professor of surgery and the program director for the Advanced GI Minimally Invasive Surgery Fellowship. Thank you for giving me the opportunity to present my project here today. It's titled To Wean or Not to Wean, PPI Management After Anti-Reflux Surgery. Um, this is something that is very relevant to my practice. I have um, a specialty in foregut surgery or gastroesophageal surgery and have trained in various institutions across the United States and have worked with residents and fellows who also trained in various institutions across the United States and have noticed a great variability in the protocols in which PPI medications are managed after successful anti-reflux surgery. That spawned my interest in this study, and I'm excited to present our findings today. I have personal disclosures as a consultant with Endogastric Solutions and Merit Medical. Other members of the study team have received support from the following companies. So anti-reflux surgery is the gold standard for medically refractory gastroesophageal reflux disease. It's been proven to be safe and effective and sustainable. About 30,000 procedures are performed annually in the United States. Even though this seems like a large volume of procedures, it's still just a fraction of what could be performed, with about 0.4% of patients who would benefit from anti-reflux surgery actually undergoing a surgery. Nevertheless, this does lead to a great deal of scenarios where antacid medication needs to be managed in the post-operative period. It's very common for medically refractory gastroesophageal reflux disease patients to be taking PPIs for quite some time before undergoing anti-reflux surgery. Um, it's notable that anti-reflux surgery restores the anti-reflux barrier, altering the GI anatomy, and therefore eliminating the need for proton pump inhibitors after anti-reflux surgery um, most of the time. Uh, we know that uh, there are significant side effects from long-term use of proton pump inhibitors and significant cost for the patient. So if these medicines could be stopped or weaned after successful anti-reflux surgery, it would offer many benefits. In general, there's two main ways of discontinuing proton pump inhibitors. The first would be an abrupt cessation immediately after surgery, and the second would be some form of a taper or a wean protocol after anti-reflux surgery. This is a compilation of the evidence thus far surrounding the randomized control trials, expert level consensus statements on weaning protocols. The highlight from this slide is that these studies have been performed on medical patients, not surgical patients. There's no real evidence on how to perform a taper or a wean on patients who have had altered GI anatomy. So we're not certain if the findings of these studies would directly apply to a surgical patient who's undergone anti-reflux surgery. So again, this is a big key point stating the problem is that there's no information about discontinuation in the post-surgical setting. So a few keynotes regarding the surgical group that would be different from the medical group. So these patients likely have more severe disease, not all of the time, but likely this cohort would have more severe disease. Likely taking PPIs for a longer duration of time in high doses. After surgery, their GI anatomy is altered, the reflux is immediately stopped, so therefore you could postulate that they may no longer need the medicines immediately. So these are things we don't know, but could only assume. So again, the PPI management after anti-reflux surgery has not been studied. There's no evidence-based guideline. There's no expert level recommendation. And our study sought to investigate the current practice in the United States. So what we did was we created a survey, an electronic survey, asking several questions about postoperative PPI management. We specifically wanted to know discontinuation protocols and the timing of them. We also asked reasons behind the decision making. These questions were up to 7 questions in a row. The survey lasted on average about 2 minutes, and we kept it open for 11 weeks. We used an online format using a software called Qualtrics, and this was an anonymous survey, and it had voluntary participation. So in other words, there was no incentive or reward for completing this survey. You can see an example of what the survey looked like on the right of your screen here. So this was sent electronically directly to 644 providers. These were experts in gastroenterology or foregut surgery. We used social media platforms of various American societies, American Foregut Society and SAGES, and circulated them on both their Facebook platforms and a specific online community of medical doctors called DocMatter that the American Foregut Society utilizes. We also targeted known institutions, listservs, where we knew that they had specialty training in foregut surgery. In total, we had 121 respondents, and of these respondents, 92% were surgeons. The other being gastroenterologists or possibly primary care physicians. So the first question we wanted answered was how you discontinue PPIs after reflux surgery. And there were 2 groups. The first group, 42%, almost half of respondents always and immediately stop PPIs after anti-reflux surgery. So again, most of these were surgeons. They do their anti-reflux surgery. 42% of them are stopping them on day 0. Just over half, 58% of respondents, perform some form of continuation after anti-reflux surgery. And that group is in blue. That's the group that proceeded with further questioning. So of those providers that performed a wean or taper, we asked how you wean or taper the proton pump inhibitors after anti-reflux surgery. And it was about a 50-50 split. 46% of them always taper the PPIs after anti-reflux surgery, no matter what. 47% do this selectively, depending on various things. I'll note that 7% never discontinue the PPIs after anti-reflux surgery. So no matter what, even after successful reflux surgery, they're going to maintain the PPIs. So we took those providers that performed the taper, and they continued with the questionnaire. The next question was how long you perform a taper, okay? And the overwhelming response was less than 3 months. So 92% of providers who perform a taper, either always or selectively, after anti-reflux surgery, do it within 3 months. Okay? So if you group the providers who never wean the PPIs at all, and the providers that most of them taper within 3 months, you can add them together to get 86% of respondents. So 86% of experts, whether they be foregut surgeons or gastroenterologists, are going to discontinue their PPIs within 3 months. So we wanted to know what factors influenced the decision in those that did it selectively. And you can see here that most decisions were made based on prior training, mentors, or anecdotal evidence, their personal preference. And so 81% of these decisions on how to manage proton pump inhibitors is based on very low level evidence. 19% of respondents did admit to some form of medical literature or evidence-based medicine surrounding their decision. But again, I'm not clear on what literature they were citing. It's likely that they were extrapolating the medical literature to the surgical patients. So again, we looked at the patients, the providers who did this selectively. They performed a proton pump inhibitor wean in some patients under certain scenarios and found the following. Surgical technique influenced their decision about 10% of the time. Personally, an example of this would be if we do an endoscopic fundoplication like a TIF, we typically will continue the proton pump inhibitors for 3 months to allow for mucosal healing, whereas we don't do that with other anti-reflux surgeries. The duration and dosage of the PPIs preoperatively played a role, with dosage being more important than duration. And I was happy to see that disease severity played the largest role. So whether the patient had Barrett's esophagus or the presence of preoperative esophagitis, particularly erosive disease, played the biggest role in whether or not they were continued or tapered postoperatively. There were some limitations to this study. Again, we were asking a very specific question, targeting an expert group of providers. These were primarily in academic situations and centers. When you look at the broader medical community, maybe patients who are sent back to their family practice or internal medicine doctors who don't do exclusively foregut or gastroesophageal reflux disease, it may be that they continue the PPIs at a higher rate. I'm not sure. Again, our respondents were primarily surgeons, and while this is a limitation, I also think it highlights that they play a key role in the management of these medications after surgery. Again, this was a survey reflecting current practice in the United States. This is possibly not something that would be congruent with practices in other countries or practices within the United States that may change over time. So in conclusion, proton pump inhibitor discontinuation after anti-reflux surgery is standard amongst experts, and most surgeons or gastroenterologists will be doing this discontinuation of some sort within 3 months of surgery. If they're going to wean, there's 2 main protocols with no real difference. About half of them are going to always stop immediately, and half of them are going to gradually discontinue them over the 3 months. The decisions surrounding the management of proton pump inhibitors after anti-reflux surgery is mostly driven by specific training and experience, and we certainly need more evidence-based recommendations in managing these medications in the post-surgical patient. This is a citation for the manuscript for those that are interested in reading it in its totality. There's also a shareable link here so that you can find it online. Thank you so much for allowing me the opportunity to speak with you today and present our findings. And at this time, I'll be taking questions. Thank you very much.